So when we talk about the failed pouch, I think we need to define exactly what we're calling as a failing pouch. Is it a mechanical issue related to surgery? Is it a really idiopathic pouchitis, or is it both? Or is it Crohn's disease? And it's important trying to differentiate the differences between the three. It's all about history, history, history. When did the complications start to happen? If somebody developed their complications immediately after the ileostomy closure, after pouch, that's most of the time mechanical. If somebody had 2-3 years, more than a year, no problems, then they start to get issues, that's likely a Crohn's disease. What's important, what the patient wants, it's important this is a multidisciplinary group of collaborative work, and the workup is needed. Revision and the reconstructions options are all on the table for these patients, complemented by the liberal medical care therapy, even if there is some concerns of Crohn's disease is high. And this is the infrastructure that the institution needs to understand. They need to provide the caregivers so they can deliver the care to the patients. But this is the thing that I try to teach and preach to my residents and fellows. Number one, when these patients have a pouch procedure and everything went well, and then the things did not work out, but they say the fact that, Doc, I'm happy with an ileostomy, leave me alone. Trying to convince them the other one for a redo pouch surgery is the biggest disservice. The other thing is, one sometimes cannot live happily with a permanent ileostomy because you don't have the infrastructure, merit, or the skill set. Trying to convince them go back and live with an ileostomy is also the biggest disservice. So reoperative pelvic pouch surgery starts with humility, teamwork, respecting the patient's rights, patient's opinion, pathology, unpredictability, what I talked about, operating room, consistent staff, and strategize, and repetition is very important. Do I do Crohn's, J-pouch in the setting of Crohn's disease? It's all about articulation, transparent discussion. I don't do it in a significant perineal disease with the presence of a significant small bowel obstruction. Absolutely not. If they have very limited of the above, as long as they understand what they're getting into, I am very liberal about these things because I do believe the biologics and the medical therapy can open the new era in these settings, complemented with the stem cell for the future on interested parties. Once again, this should not be driven by the surgeon. This should be driven by the patient.